Okay, so let's chat. Let's duplicate this so you can see. Maybe, maybe not. Maybe. Oh, they turned themselves off random. Interesting. Okay. There we go. Okay, so working on a nerve trunk, or we could either call it the nerve trunk, or chapter 15 gives us a couple of indications for it. So over the dermatome or the cutaneous nerve distribution, so we did more cutaneous nerve distribution. So we were doing posterior femoral cutaneous. So based on the way we had it set up, what did you all think about it?
I felt the weight on my back than on my leg.
More over the lumbar spine, more over the sacrum. Okay. So,
when we did mine, started the leg first, and then after you started the back, I didn't feel the leg, like the tingling in my leg as much as I did.
interesting. So it's interesting. Not a lot of people do it this way, but this is a cool way of doing it. If you're having someone who, like I say, displays that dermatonal or that either that dermatonal or that cutaneous, superficial cutaneous nerve kind of pain pattern. Like I said, a little bit of numbness, a little bit of tingling, a little bit of prickling sensation throughout the dermatome. So it may start in the spine and it'll work its way over the dermatome or the superficial or over the cutaneous nerve supply. So if it's a C6, it'll start kind of in the neck and start in the lateral forearm, working its way down into the hand. And so it'll be just kind of achy or dull, achy or numb or tingling or burning, any of those weird sensations. Starting from there, winding down, you're thinking dermatome or cutaneous nerve. So this is a good setup to at least try to see if it'll help. If nothing else, it'll give your patient some level of intent that you're looking at trying to fix what's going on. So remember, sensory analgesia has three primary places where we will place it. We will place it, one, we would surround the pain. So I'll erase these. So sensory analgesia. So we either, one, surround the pain. Two, we're either placing it on the dermatome. Area, and so that would be spine plus distal area. Or we can do number three, we can place it along the cutaneous nerve distribution. And it's also spine plus distal area. So those are three ways we can produce sensory analgesia for pain control. So either surrounding it along the dermatome or along the cutaneous nerve. So three ways we primarily can do it. Now, if we're doing endogenous opiates, It also has 3 places. One would be motor point. So you already know these. 2 would be trigger point. 3 would be acupuncture point. So those are the 3 areas we can apply it for both techniques. So dermatome, cutaneous nerve are surrounding it, motor point, acupuncture point, or trigger points. Okay. Any question regarding pain or IFC? Hmm? Right. So you could use different setups for it. You can use a monopolar setup for trigger point release where you put it directly on it. You can actually bipolar it and surround it if you want to try that. You can do what we were doing the other day, and we still have to kind of do this one because Ashlyn still hadn't done it. You can use the ultrasound head as a movable electrode as well. There's actually one other way we'll show you. It's not testable, but it's just fun to learn. Yes, sir?
I had a question about something that Brandy had a question earlier.
Mm-hmm.
She was doing with the Fremont. Yeah. The Fremont thing with the carrier, it still had the beat frequency on it.
Mm-hmm.
Fremont. What do we do about that?
So that's what we were talking about. So pre-mod is very similar to IFC, so it still has a beat frequency. The difference is instead of it modulating or using the high frequency coming through the actual electrodes, the high frequency is done inside of the machine. So it literally has a similarity to IFC, but whereas IFC requires 4 electrodes to do its high frequency, so IFC requires 4 electrodes crossed so that high frequency can be delivered. With pre-mod, its high frequency is done in the device itself. So it's creating the high frequency in the device via the AC wave form that forms it, and then you can deliver it to the body using your own frequency for your treatment. So it's similar to IFC. So it'll have a beat frequency, it'll have a carrier frequency just like IFC, but we don't use it in the same manner. So it'll still have a carrier frequency. We're able to set our treatment frequency differently. Whereas with IFC, it has the carrier frequency and it has a treatment frequency, and together, as they are running through the tissues differently, they interfere, and that's what creates the penetration deeper into the skin. So one is done through the electrodes, one is done through the machine as it relates to how we can get high frequency current into the tissue. Good question. Any other ones? Any other ones? This is good. So pain, we understand, we're getting there. We'll keep working through it. Now we're going to move to neuromuscular stimulation, electrical stimulation, or NMES. So we're heading to chapter 13. To the NMES chapter. NMES. Okay. Okay, so chapter 13, we'll begin on page 343. So, Nelson Mandela wrote, "A good head and a good heart are always a formidable combination." Don't know how that's relevant, but it's on there, so we'll talk about it. Okay. It says a little bit further down in the pink part of the paragraph there, the purpose of this chapter are to demonstrate the clinical use of surface electrical stimulation to accomplish therapeutic goals and to explore guidelines in clinical decision making and intervention. Over on the right, this chapter considers the use of neuromuscular electrical stimulation, or NMES is what we would call that, in physical therapy. It is defined as the use of electrical stimulation for activation of muscle through stimulation of an intact peripheral nerve. So that's the biggest thing. Highlight that. It has to be an intact peripheral nerve. And the peripheral nerves are usually the same name nerves that you already know that we'll review a little bit later, like musculocutaneous and median and ulnar, and those are all femoral. Those are peripheral nerves, the name nerves. So we're stimulating an intact nerve, and by doing that, we will produce motor function or motor contraction of a muscle. So the goal is to stimulate an intact peripheral nerve, and that's going to cause a motor response to the corresponding muscle. Functional electrical stim are different forms of NMES. They can be used as a substitute for an orthotic device like an AFO or things like that, and we'll show you how we do that, to activate muscle contractions if the muscle has an impaired function. Also to assist in functional activities such as standing or grasping an object. So we can use E-stim in case we're trying to substitute for one muscle group as it relates to it being paralyzed or not functioning. So it won't do all of the body, but it may do parts of the body. So let's show you this. Let's try this then. I thought I had a video of it. Okay. So this one is good. No. Okay. Yep, this is the one I want. the foot. Now we're going to use an E-stim device called functional electrical stim, and it helps to contract when his foot is off the ground, and it allows for him to do a swing pattern. So it stops his foot from dropping. Pretty cool. So, yeah, good stuff. So that's called FES, or functional electrical stim. That's when we use E-stim to substitute for weakened muscles where they don't have the stability to contract either for prolonged periods over time, or they don't have enough strength to contract to perform a functional action. We can substitute for that. So we do not use FES for de-innervated muscle, meaning where there is no communication between the peripheral nerve and the muscle. That's de-innervated. We don't do that. Usually it's going to either be because it's weak and it needs strengthening, we would stimulate it, or it's because it lacks the endurance. So the nerve has some damage, it lacks the abilities to recruit more motor unit strength, or it lacks endurance. So we would do FES for that. Anybody ever see anyone use one of those clinically? Not yet? Cool, okay. We'll play with it. We don't have one in-house. I borrow one from some friends who have a clinic, so we'll play with that a little bit later. That may be tomorrow. Okay? Oh. Okay. Good stuff. So the book lets us know that NMES, or neuromuscular E-stim, requires an intact or at least partially intact peripheral nerve to respond to stimulation. So I cannot do this without an intact or partially intact peripheral nerve. The stimulus must reach the spinal cord so that the appropriate response to the stimulus can be expected. If a patient has what we call a compromised loop, which is the communication between the periphery where the nerve is being stimulated, the spinal cord where the information goes, to the brain, which coordinates a response, back down to the muscle. If there is some compromise in those things, then we're going to have trouble. So the loop is from the peripheral nerve that we're stimulating into the spinal cord, to the brain, from the brain back to the spinal cord, back to the muscle to perform the action. Okay. So it says, in the case of a partial de-innervation because of peripheral neuropathy or metabolic or neurologic origins, it may not be possible to stimulate a contraction of any more strength than a patient is able to produce voluntarily. So this does not, if it's de-innervated, it does not re-innervate an area. It's going to stim what you have, but it does not produce re-innervation. Okay. Yes. So the book talks about another type of E-stim. Is not what we're going to do. Electrical muscle stimulation, EMS, is the type of stim you would do to stimulate a de-innervated muscle. So where there's no communication between the peripheral nerve and the muscle, it's now a de-innervated muscle. We would use EMS to stimulate those. And they usually have different devices. They're little yellow devices you could see. You may see them somewhere in clinic. So they'll look like this. If you see one of these in the clinic, that's what that device is. That's a de-innervated muscle nerve stimulator. Sorry about that. Trying to sign you up for 20% off. So that's what it looks like. So it has here a water-soaked electrode to serve as the disbursement electrode. And then you have the de-innervated muscle stimulator here. You put it over the muscle you want stimulated. You click the button and it shoots an electrical current into the muscle strong enough with a pulse duration long enough. So you're talking almost a full second, and it will allow for that muscle to contract. So since we don't do it here very honestly, and it's not a lot of what we would do therapeutically, we don't do it here. We don't cover it a whole lot, but I at least want you to be familiar with the terminology. So in case you're ever in a clinic, you see someone pull one of those out, you'll go, oh crap, I know what that is. That's an EMS device. So we won't deal with nerve conduction velocity tests today, so don't worry about that. So the book says there are a few contraindications to NMES. So NMES does have a few contraindications. Demand pacemakers, which is a contraindication to all of them. Also, box 13.1 gives us all of them. Demand pacemaker is one of the main ones that it mentions, but stick with the ones we talked about in chapter 11, because those are still relevant even here for chapter 13. So they still give pregnancy, any other pacemaker. So all of those, just stick with the ones from chapter 11. Okay, any questions there? Okay, so the book talks about for therapeutic currents, individuals may respond negatively when first introduced to a stimulation program, and that's true. That's not a joke. Because NMES is going to be a little bit different than TENS was, or pain reduction E-stim. So that was usually for more patient comfort. It's to reduce pain. It feels good. NMES doesn't feel bad, but its job is to produce motor contractions or produce motor response somehow. We're going to try to produce motor. So that sometimes is a little bit more uncomfortable for people, but we're going to work through it. Okay? It says the two main concerns in planning a NMES program, the quality of the stimulation of the muscle contraction, and then two, patient comfort leading to cooperation. Both are going to be greatly affected by parameters that we choose for our E-stim device. The success is not based on the stimulator chosen, because there are a lot of different ones that do the same job. Success is going to be determined by parameters. So everything we teach you is about parameters. So once you learn parameters, then the next thing you have to figure out is, does the waveform I'm choosing have the ability to meet those parameters? Same way with endogenous opiates. Why can't we use Pre-Mod or IFC for endogenous opiates? Frequency won't get low enough, so it doesn't meet the parameters needed to work on that protocol. Same way here. So everything is still about parameters. Okay, so let's look at some of the things that help parameter-wise. Number one is going to be waveforms. It says patient comfort has been investigated. 3 studies investigated comparative comforts with different waveforms. One found that there was no clear choice amongst 3 symmetrical biphasic waveforms, and that differences were patient-specific. In a comparison of symmetrical and asymmetrical, Bowen and Baker found that normal female subjects preferred symmetrical waveform when a large muscle group was being stimulated. But another similar study, it was found that when the target muscle groups were small, normal subjects preferred asymmetrical. So, in a study comparing frequencies with asymmetrical biphasic waveforms, some authors demonstrate a preference for higher frequencies between 30, 50, and 100 were tested in stimulation of tetanic contraction of the quads. So frequency varies, but usually if I'm trying to get tetany, I want to be somewhere around 30, between 30 to 50. And we'll go through different ones, but usually we'll go through that when we get to pulse rate. But usually frequency is somewhere between 30 and 50 pulses per second, or 30 to 50 hertz if I'm using an AC waveform. Okay. So it says monophasic and biphasic waveforms have been shown to produce greater torque and less fatigue than polyphasic waveforms. We don't have anything that's polyphasic here, so we can't test that theory. So the goal is the waveforms that can be used for it, I put here on the machine. Symmetrical biphasic can be used, is usually preferred. It depends on the person. Asymmetrical biphasic for smaller muscles. AC current that we can use is a Russian current. We'll talk about what Russian is. We can also use another pulse current, VMS, variable muscle stim, depending on the device you're using. And there is one device here, the big one, the big fancy one over here to the left, that will allow you to set up IFC as a motor nerve stimulator. So it's only one. Okay. Any questions there? So those are the different waveforms we can use, either AC or pulse waveforms, that will give us good results when we're trying to do NMES. Okay, so with amplitude or intensity, or how much they feel, it must be gradually increased when we're first introducing stimulation to patients. A patient will become comfortable with the sensation within the first 15 minutes of being gradually introduced to the stim. We usually don't have that long to stim a person. Most times, if you're doing it specifically in the outpatient setting, most time you're going to get 30 minutes to treat the patient. If you spent an entire 15 minutes just on E-stim, you have neglected the patient and everything that's going on. There may be times when you may need to do longer, but usually 10, 12 at the most. Okay. The quality of a stimulated muscle contraction is determined by a number of different factors, including amplitude, pulse duration, strength duration curve, stimulus frequency, and the duty cycle. We hadn't covered duty cycle yet, but it's in here, and we'll cover duty cycle. Okay. Increasing the amplitude will cause the recruitment of additional nerve fibers. So when I'm increasing amplitude, I'm stimulating more. I'm stimulating more motor units, and that's going to give me a more progressive contraction. Okay. So amplitude will help us with that. If a portable E-stim is being used, it is more difficult to determine the amount of current delivered because the device uses an arbitrary 0 to whatever phase. So it's not as calculated down to the number as some of the larger machines, but it's very good. Says, however, regardless of the type of stimulator used, the therapist must rely on the muscle response observed and the patient's tolerance. So we're looking to produce a motor nerve depolarization. We're looking for contraction. So amplitude is going to be important. How strong or how much they feel. Next, we have pulse duration. This is for pulse currents. It has a corresponding relationship to amplitude. They have a strength duration curve at the bottom. Shorter pulse durations, which are usually below 40 milliseconds, require a much higher stimulus amplitude. So choosing not just the right waveform, but choosing one that has a pulse width long enough that it's going to depolarize the cells you're trying to depolarize. Okay. Yeah. Okay. So yeah, that's about all. Won't cover all that. Then the next thing we'll talk about is pulse rate. Pulse rate, this is our frequency. It says on many of the units, the controls, we're able to control, the primary things we're able to control are amplitude and pulse rate, dealing with our frequency. As the rate increases, the rate of motor nerve firing rises, and the twitch response we normally would be getting can lead to a fused motor response. So basically, as we increase frequency, we go from twitch motor response to fused tetany, where it's locking my arm in. Or we go from, let me say it this way. So based on frequency, we go from twitch, that's what you were feeling the other day, twitch, to tetany, where it's just contracted, and we can get all the way to fused tetany, where it moves the extremity for us. So we can have an amplitude and a frequency high enough that it's going to move the body part for us. You won't have to move it. When we do wrist extension, it's going to lift your wrist up into extension whether you want it to go or not. Okay. Says, however, there is a difference between voluntary and electrically induced contractions. An electrically induced contraction results in a reverse motor unit recruitment. Highlight that. We talked about this already. This is when it gets really, really important. It gives us a reverse motor unit recruitment. It's going to recruit larger superficial motor units first. And it's going to have synchronous activity of the nerve and muscle fiber. Whereas in normal, we want to recruit smaller fatigue resistance fibers and then get to the larger fibers only as we need it. Okay. Okay. It says a fused tetanic contraction can occur at frequencies as low as 12 pulses per second. So it doesn't have to be really high, 50, 100, things like that. It can be a low one just depending on how small the muscle is or how superficial the motor nerve and the muscle are. If it's really superficial, then we'll have more opportunity. Okay. Any questions there so far? Let's get you up moving around before you pass out, fall asleep. So stand, move around a little bit. We'll take about 3 minutes, and then we'll come back and talk about timing modulation. Turn this back on. There we go. Okay, so there are a couple of things that are different overall when it comes to the use of NMES versus TENS. So TENS, really all we had to worry about was having our pulse or our phase duration set appropriately. So we want a shorter pulse or phase duration. If we want to do sensory analgesia, we want a longer pulse or phase duration if we want to do endogenous opiates. And then we also had to look at frequency. High frequency for sensory analgesia, low frequency for endogenous opiate release. If we're doing painful or hyperstimulation, then that changes. When it comes to NMES, there's some other values that we have to set that are just as important. One of those will be what we call duty cycle. Duty cycle. And essentially all duty cycle is, as it relates to NMES, is going to be our on-off time listed in a ratio. Okay. Most devices are going to be preset with certain on and off times. They may do a 1-5, which would be 10 seconds on, 50 seconds off. They may do a 1-3, which would be 10 seconds on, 30 seconds off. Or they may do a 5-5. They may do 5 seconds on, 5 seconds off. Some will go to 1-2. It just depends on the device. Those will be your on and off times. How long the current will be on, how long it's flowing, and then how long the current will be off, where there's a rest break. So that's one of the main differences between NMES and TENS, is that current is going to be on for a period and it's going to be off for a period. So far, we haven't had current to ever turn off when we're dealing with TENS or pain relief. Now for IFC, we can modulate the vector scan, or we can modulate vector, which is an amplitude modulation, or we can do a sweep, which modulates the frequency. But the current was always still on. Here, when we're using NMES, there's going to be time when you don't feel current at all. Current is going to be completely off. Then it's going to come back on for a period of time. That's our on-off time. Okay? So this is talking about. So look over to the right on page 347 at the top. So it's talking about off time. Let's talk about that before we talk about duty cycle. Okay. Okay. So it says the off time represents the time during which a muscle is able to recover from a previous contraction and is at rest. Insufficient rest leads to rapid fatigue and limits success. The majority of clinical intervention paradigms will can use a 1 to 3 or 1 to 5, a 1 to 3 or 1 to 5 on-off ratio, with the typical on time being between 2 to 10 seconds. Okay. So down at the bottom, it says the on time chosen can often affect comfort because there's a range of on time that can range from anywhere from 2 to 10 seconds. Your documentation should include both our duty cycle ratio and the actual time. So we'll document on-off time, and we'll document how long the current actually was going. So we may document patient, let's see here, patient received NMES to left quad. We can then tell the setup. We did a bipolar setup. We did a 1 to 5 ratio with 10-second on time. So I need both of those in there. So 1 to 5 ratio tells me it was on for 10 and it was off for 50. So on-off time. Okay, that's the most important one, because if you set too short of an on-off time, your patient is going to go through rapid fatigue. The faster you're off, the shorter your off time, the more fatigued your patient is going to become. Now, if I'm working with the patient I'm trying to fatigue, like athletes, then that's okay. But I don't want to set up too short of an on-off time for the 70-year-old grandmother who just had her knee replaced. So you want to modulate your on-off time based on your patient type. Right, the shorter the off time, the more fatigued you're going to become. Two things that'll increase fatigue when we're doing NMES: short off times and too high frequencies. two things that will increase patient fatigue with NMES. So these are two things that are going to cause patient fatigue with NMES. So two things that increases patient fatigue. One is going to be an off time that's too short, or frequency too high. So both of those will increase patient fatigue. Okay, so on-off time is the most important one. But on some machines, especially when you're dealing with Russian, you're going to see it also have a term called duty cycle. Duty cycle. So what is the duty cycle? The duty cycle is the on time that the machine is on divided by the total time that the machine has the ability to be on. So it's true on time divided by the total available time of the device. And we divide that by 100. So in this example, if I use a 10-second on time and I have a 1:5 ratio, so I have 10-second on, I have a 50-second off, so my 10 on is going to be divided by 60 because I'm adding 10 plus 50 as my total time that the current is potentially available. Not when it's on, how long it's actually available. So 10 divided by 60 would be that. Gives me 0.16 times that by 100. That's a 16% duty cycle. So it's on time, how long the current is actually on, divided by total time. Time the machine is on and time the machine is off. Whatever you set as that protocol. There will be some 5/5s where it's on for 5, off for 5, and that's usually a 50% duty cycle. So all duty cycle represents is the total amount of time that current will need to be available for use during your protocol treatment. How long will I need current during the protocol treatment? Most duty cycles are going to come preset at 50%. Because you will never have a situation where you need more than 50% duty cycle. You should never have your on time exceed your off time. So most machines will come preset with a 50% duty cycle. Almost kind of like IFC comes preset with a 4,000 hertz carrier wave. Very, very similar. So on-off time is the most important to what we're going to do. Duty cycle is just a representation of on time versus total time. It's not vitally important. It's just how long current needs to be available. On-off time is the most important thing because it tells you how you are setting up your actual protocol. Okay, any question there? The next characteristic that's completely different about NMES versus TENS is the use of what we call a ramp. A ramp. Now, most people confuse ramp with, most people will try to put ramp in the same category as rise time, but they're not. It's going to sound similar, but it's not rise time. Rise time is going to be pre-selected by the machine manufacturer. Let me say that early. Rise time is pre-selected by the machine manufacturer. We can't set rise time. We have no control over it. Rise time pre-selected by the manufacturer. Ramp time, however, is the time it takes for the machine to go from no current or zero amplitude, let's say it that way. It's the time it takes the machine to go from zero amplitude to peak amplitude that we set. So this is dealing with whatever the peak amplitude we set. So let's give you an example. So let's say I am doing a motor nerve stimulation of my quad. Okay, this is my amplitude here. So 0, let's say 5, 10, 20. Okay. Let's say I'm getting ready to do my stimulation. I turn it on. If it goes from 0 to 20 straight up, that's usually a 0-second ramp. I have no ramp at all. Goes straight from 0 to 20. If I set a 2-second ramp, that means it's going to take me 2 seconds to go from 0 to 20. So it's a little bit more comfortable. If I have 10 seconds worth of total current, then that means it's going to run. So it's going to ramp for 2, it's going to run for 6, and then it's going to go back from that peak amplitude back down to 0 for another 2 seconds. Ramp is always on time. Ramp is always blended into your on time. So when you're setting an on time, you need to account for ramp. Ramp is extremely useful for patient comfort. We like ramp because it increases patient comfort. Nobody wants a machine that goes from 0 to 100 with no, just instant. No, it doesn't go gradually toward that amplitude. It goes from 0 all the way up to the max amplitude. Woo! Feels like a rocket shooting into you. So we want to account for ramp. So the book tells us a ramp is another modulation. The current is going to be gradually increasing or decreasing with a plateau of stimulation. So it's going to have a ramp time, whatever ramp time we set is going to ramp up for that long and ramp down for that long. Then we subtract those two numbers from the on time, and that gives us our time of plateau when it's at its peak amplitude. So if I want to use a ramp, let's say I want to use ramp. Let's say I want to use a ramp. I tried it without a ramp, it's uncomfortable. So I want to use a 1-5 protocol with the 10-second on time. So if I'm using a 1 to 5 protocol with the 10-second on time, then, and I want to also use a 2-second ramp. So a 1 to 5 protocol with 10-second on with a 2-second ramp. So 1 to 5 protocol is going to be on for 10 seconds and it's going to be off for 50 seconds. But I still need to add in my 2-second ramp. So I'm going to have 2 seconds where it's increasing and 2 seconds decreasing. So my total sustained time out of this 10 seconds is only going to be 6 seconds of plateau amplitude. So whatever I set. So if my amplitude, I set my plateau amplitude at, like I say, 10. Then I'm only going to spend 6 seconds at 10. The other 2 seconds are ramping up to that, and then I'm spending another 2 seconds ramping down from that. Some machines will let you set a ramp up and a ramp down. That really expensive one. Most will pre-select it for both. So whatever you set for ramp is going to do it for both. So you don't get a chance to choose. Usually you don't get a chance to choose the ramp down. It's just going to say ramp. And so it's going to be for both. Okay. If you have on one of the really expensive machines, yes. Most machines, no. It's just going to be whatever ramp you set is going to be for both. But I think on the really big one, I think it allows for you to select ramp up and ramp down, if I'm not mistaken. Okay. Any other questions? All righty. Okay, let's see here. What time is it? We got a little time. We'll play. Okay, so hold that thought. to the portable tins you've already used. Some of them, you will need to steal the battery out of the portable tins device. I forgot to get batteries. I didn't get batteries today. Sure about that. I'll leave it there. Walmart. Totally slipped my mind. So we'll definitely need a battery. Okay. So the first thing we do, not grab the device, but we grab manual. Very good. Look into your manual. Let's go to page number 4. I thought, no, page 5. Sorry about that. That's crazy. That don't make sense. Yes, page 5. Okay. So, what type of waveform are we using here? Asymmetrical pulse biphasic. Yeah, asymmetrical biphasic. So we're using a pulse current, specifically asymmetrical biphasic. So this will be good for, very good, little muscle. Okay, so that's what we're using here. Okay, so that works well. It has a pulse width that can range from 50 pulses per second. I mean, from 50 microseconds all the way up to 300 microseconds, which makes it sufficient enough to depolarize a motor nerve. So it has, let me turn this on. So it has, again, so we're using with the portable NMES, we're using a pulsatile current, a pulsatile waveform, asymmetrical biphasic. It will be balanced, so it's not unbalanced, asymmetrical biphasic. It has it can vary its pulse width from as low as 50 microseconds to 300. 300 is long enough to stimulate or long enough to depolarize any motor nerve. So it's strong enough to depolarize motor nerve. Okay, so if you look at the top, you'll see the rollers. It has 0 through 8 on the top for the amplitude setting. Go ahead and turn it to the right, and that should turn the device on. Slide the front cover down, and this is how you set it. Ron Popeil, set it and forget it. Okay, so when you're setting it, you should see where it says channel 1, channel 2, and then it has mode. It has 3 different modes. It has synchronous, constant, and alternate. All of that'll make sense, I promise you. All of them actually make really good sense. For setting the device early on, we want to go to constant. So you want to be in constant mode to set your device. Then you want to go to your settings. You want to have a pulse width up around at least 250, and you can go higher than that. You can go up to 300. And then you want to have your frequency or your rate down at about 35. And then you can set your total time that you want there. So that's how you set your device. Alrighty? So each person now get 2 electrodes, and we're going to connect them appropriately. So we're going to put them over a motor point. There's a PowerPoint that should be already loaded on your thing dealing with motor points. So this, so I'll show you exactly what I want you to do. So this is another one. So we're going to do wrist, let's do wrist flexion. We'll do flexor carpi radialis. So 1 electrode, so you'll put 1 electrode right about here. This is where the motor point is here. Let me make it larger so you can see it. So proximal forearm, you're going to connect the black lead to that one, which is called the cathode. So the cathode is going to go over the motor point. The black lead or the cathode over the motor point. Then your anode is going to go over the tendons, which is still in the proximal forearm, right about here. So the red will go in the proximal, like slightly inferior or distal to the black one. Leave about 1 inch of space in between them. And you're going to still position it on the anterior forearm. Yours is not working? I don't know. Plug yourself into one of the channels.
Hey, do we not set our own off time?
Not yet. Not yet. We want to get it set to the right thing. So once you have those things basically set, you have your anode over the motor point, you have your cathode over the motor point, your anode slightly distal to that. You plugged yourself in. Now you want to start to slowly turn the amplitude up until you start to get a contraction. And then after you get a contraction, turn it even further and get what we call fused tetany, where it actually moves your wrist for you. So your first goal is to just get a motor contraction out of it. You're going to turn your amplitude up slowly till you get a contraction, and then you're going to keep turning it until you get a fused tetany, where it actually moves your wrist for you. Once you get fused tetany, turn it down and ease off. Very good. So it should do it for you. So you should get a twitch first, and then you should get fused tetany. Still? Oh, I got you. Just scream like, give me some help. Mister, help, please, give me help.
Thank you. Is this the right place when you put it?
So this one here, a little bit up there, right in the middle. Yep, right about there. A little bit down for yours, right about there. And right about here, right in the center. Let's get you connected. Yep, are y'all plugged in? Yep.
Is it up? Oh.
So start turning it up. And you want to get.
Parameters, right?
Yeah, so like let's see here. So, alrighty, so you want to be alternate. So you want to go mode, constant, and then you want to set 35, about 250. Okay, now start turning it up from there. And you want to feel it where it gives you a twitch, and then you want to get it to fuse tetany. There we go. That's some fuse tetany there. I like it. Oh yeah. Strong. Strong. Okay. So once you get fuse tetany, so there are some things we're going to do that's going to need fuse tetany. Most of the things we're going to do is only going to need a strong motor response. So back it down once you get fuse tetany. You don't have to leave it there. Once you get it, go ahead and back it down. It'll fatigue you. Frequency, too much of it, it'll make you tired. So most of the things we want to do, we'll just use a motor response. So once you have found that, and you understand that number, so you want to turn it back up to where you get a strong motor response, but not fuse tetany. Strong motor, not fuse tetany. Once you find that number, then you want to go back into mode again. And then you're going to go to synchronous. And now you're going to be able to set your ramp time and your on time and your off time. So 2-second ramp. For your on time, put 10 seconds. And then for your off time, 30 seconds. And then let it ride. On time 10, off time 30, 2-second ramp. So on 10, off 30, 2-second ramp. Synchronous. Okay? And what you'll notice is once you click set, both of those channels are going to come on together, and both of your arms will get a strong motor response. And it's going to sustain for a total of 10 seconds. 2 seconds will be your ramp, 6 seconds will be your contraction, 2 seconds will be your off, or your ramp down. I shouldn't say that. Oh yeah, 30 seconds is a long time when you're doing this. Oh my gosh. So I'm coming. Hang on. second?